center because the number of flights are less. At least now the flights are reopened. Till last month there were no domestic flights available. Road traffic accidents are less, which is a blessing in one sense, but as a consequence, the donor organs are less. And at the same time, the hospital bills are climbing as patients are waiting in intensive care on multiple ionic stroke and die. So this is the tragedy, and this is true all over the world. This is true. In fact, this is a brief report from the United States, end of July. Trends in U.S. heart transplant waitlist activity again, dramatic drop in the number of donor organs, both in Europe and the US. So we need a fresh look at how we approach end-stage heart failure, because if the number of donor organs is limited, perhaps we should have redefined how they are utilized, and we should perhaps use the limited number of donor hearts for those who are best likely to get 15 or 20 years survival out of it, and the other patients are perhaps better treated with a VAD. The candidates for transplant and VAD are to a large extent similar, except for some differences which I shall come to later on. And LVAD is nothing but, as you can see, mechanical pump. Heart is nothing but a pump which pumps blood. So the earliest VADs were pulsatile pumps, because we are provided by nature with a pulsatile heart. So the earliest engineering endeavors try to duplicate the normal heart by providing a pulse. The heart has two ventricles, right and left, but to make both ventricles beat in synchrony mechanically in the 80s and 90s was not easy. So scientists of that generation focused on replacing only the left side of the heart, because that's a dominant heart failure because of left ventricular failure, and depended upon inherent native right ventricular contractility for the heart to function. So these pulsatile pumps were bulky, because when you have to have a pulse, the entire cardiac output has to be given in a short time, in the 1.3 seconds available for the systolic time interval. So the amount of blood which had to be pumped in a very short time had to be quite large. So the tubes had to be much bigger, the pump had to be bigger, and of course you needed an inflow and an outflow valve. All the cardiologists in the audience know that even though valve replacement started in the 60s, they're still battling after 16 years to achieve what a normal human valve can do. So engineering a valve is not easy. So when you make a pulsatile pump, the valves give trouble. At the end of 1 or 2 years, you have clots in the valve, you have degeneration of the valves. So the science moves towards continuous flow pumps. You don't need to necessarily give 5 liters of flow by a stroke volume of 80 cc times 70 beats a minute. You could give the whole flow continuously without pausing. One of the advantages of a continuous flow pump is you don't need a valve. And since the flow is continuous, the tubing size can be smaller and the pumps can be miniaturized to very small sizes. So if you have a small pump, the amount of invasiveness of the human body and the heart becomes much less. And Hemant showed this. This is the Heartfare pump. It's the smallest pump currently available in the world market. It's around 150 grams, the size of a golf ball. And the other pump, of course, is the HeartMate 3 pump. Both are centrifugal pumps. So you have a small little wire which is the size of your charging cable for your mobile phone, which comes out of the body, because from mobile phones we know the importance of battery power. So you cannot have a pump implanted inside the heart which runs out of battery. So you have a small cable which comes out of the chest cavity, and there are a couple of batteries which are worn on the belt. And these batteries give you an untethered mobility for up to 18 hours. So at night when you go back to sleep, you plug on the mains and get these batteries charged. And that's the current technology. But there are still some disadvantages of this, because when you have a cable coming out of the body, the exit site can get infected, especially in a hot and humid country like India, where in summer months you need to take a shower several times in a day. And each time you take a shower, you need to make sure that the exit side doesn't get wet. So you need to wrap yourself up with plastic gear that the company provides. But it's not really as cumbersome. So now there have been some recent advances. Notably, an Israeli company has come with a mechanism by which these pumps can be powered transcutaneously without breaching the skin barrier, which gives you the possibility that you don't have anything which is outside and is completely implantable. It's still not universally available, but I expect in the next couple of years that technology will come in. So currently we have these three pumps which are FDA approved. You have to understand one thing is the physiology. It's not like a pacemaker where you put in this device and forget it. These pumps require some knowledge of physiology to manage. These pumps are not preload sensitive. It's a strange and strong word to use. Preload sensitivity is nothing but the Frank-Starling curve. We all know the Frank-Starling curve of the normal heart, which means it's a blue graph. As the filling pressure increases, the stroke volume increases. Unfortunately, the amount of cleverness nature has used in designing our hearts could not be displayed by engineers making artificial heart pumps. The yellow and the green are the valves available in the market. So even if the filling pressures are low, they continue to spin at the same rate that they have been doing. As a consequence, if for whatever reason the amount of blood flowing into the left ventricle is less, the walls of the ventricle can get sucked in. And this can happen if there's hypovolemia, if there's pulmonary hypertension, or if the right ventricular function becomes poor. These are called suction events. And the other side is afterload sensitivity. A normal heart is also afterload sensitive. That's why afterload reducing therapy works in heart failure. Nevertheless, for most of the usual ranges of blood pressure to be encountered, there's not much of a difference in stroke volume between a blood pressure of 110 and a blood pressure of 130. Whereas these mechanical pumps are very afterload sensitive, centrifugal pumps more than axial. As a consequence, when you have a mean pressure of 100, the flow can be as low as 2.5 liters, and the mean pressure of 55 can be as high as 8. So imagine a 65-year-old man with chronic hypertension, the creatinine of 1.8, whose kidneys make urine once the mean pressure is more than 90. So after the pump is implanted, if you keep the mean pressure around 90, the flows are low, around 2.5 to 3 liters, and that's not high enough to treat heart failure. So if you lower the blood pressure so that the flow increases, then the renal perfusion pressure becomes less and they may not be making urine. So you need to have some kind of understanding of the physiology and adjust the pressure and the flow to manage these patients. Other thing which is important is the right ventricular function of these patients has to be adequate, if not normal, because these are left ventricular assist devices. If the left ventricular output increases from say 2 liters a minute to 6 liters a minute because we're putting a pump, those 6 liters will come back to the right side of the heart, and if the right side of the heart cannot accommodate those 6 liters over a period of 2 or 3 beats, the left ventricle will not have enough blood coming into it. So right ventricular function is of crucial importance in case selection for LVADs. So on this basis, when you see a patient in the outpatient clinic or in OPD, if you see a patient with poor left ventricular function and the right ventricle is good, and this can be estimated both clinically and by echocardiography, both transplants and VADs are possible. If the PVR is high, LVAD is preferred. If the pulmonary vascular resistance is low, both transplants and LVADs are possible. If the right ventricular function is poor, then the treatment of choice is a transplant. And if you have a poor right ventricular function along with high pulmonary vascular resistance, this is a difficult situation. This patient has come to you late, and this requires a much more sophisticated analysis of the right ventricular function using load independent measures of organ function. So hopefully most surgeons don't like to see this situation because these are not easy patients to treat. You're looking at 5 ventricular support. So typically patients need to be referred before they reach this condition. Not every patient who comes to you comes in a stable condition. A lot of patients are in cardiogenic shock. There was a very nice presentation in ECMO. So this is an example. This young woman was airlifted from Delhi on an air ambulance. You can see her on a balloon pump, intubated on multiple inotropes. She landed in a hospital and 2 days later had a cardiac arrest. She was massaged for 35 minutes and ECMO was instituted. It's 2 days after the ECMO. And over the next 4 days, she had vigorous diuresis of almost 18 liters of urine, and she underwent the VAD implant. And 3 weeks later, this is her in Marina Beach in Chennai. So excellent recovery as possible from almost near death with modern technology. The implantation of these pumps is pretty easy. This patient is getting a valve implant on ECMO, so it's like we take a series of sutures like you would for the valve replacement, and we sew in a sewing ring like this, and then an incision is made in the ventricle, and the pump is implanted. So technically, these are not difficult pumps to implant. As I said, managing and decision making in terms of when you should do them and how to manage them with the patient. We now have another technology for inhaler pump as a bridge to final implant.